Welcome to ED Debrief, where data meets the gurney. I am your guide for today's session.
And I'm here to make sure you survive your next shift. And I mean, more importantly, that your patient does.
Yeah, exactly. And, today feels a little different for us. Usually we are talking about sepsis protocols or massive transfusion guidelines.
The loud stuff.
Right, the loud stuff. But today we are tackling Chapter 294, Intimate Partner Violence and Abuse. And we're treating this deep dive like a grand round session for a resident who is just about to finish their training.
Which really is the perfect time to have this conversation because, frankly, a lot of residents and attendings, for that matter, they view this topic as social work.
Yeah, I think it's a pretty common sentiment.
It is. They think their job is to stitch the laceration, set the bone, and then, just call the social worker to handle the rest.
Because we're trained to fix the physiology, right? We want to fix the immediate mechanical problem.
We are. But here is a reality check for you listening today. Intimate partner violence, or IPV, is trauma medicine. Plain and simple.
Trauma medicine.
Absolutely. Think about it this way. If you miss a subarachnoid hemorrhage, the patient dies. If you miss the signs of escalating IPV, the patient also dies.
The mechanism is just different.
Exactly. The mechanism of death is different, and it's often delayed. Our mission today is to identify the invisible trauma that kills patients after they leave our care.
Wow. That's a heavy frame, but a necessary one, I think. So let's look at our roadmap for today. We are breaking this deep dive into 4 distinct sectors.
Right.
We will start with the landscape.
Right.
So what IPV actually looks like when it walks through the ED doors. Then the evidence. The forensics and documentation traps that, frankly, get physicians sued.
Yeah, the legal landmines. And then we move to the management. This is what I call the binder section.
The cheat sheet.
Exactly. The specific prophylactic cocktails and the exact dosages you need to memorize. And finally, we will hit the PBEM edge.
And just for the interns listening who might be new to the acronyms, when we say PBM, we are talking about the Philippine Board of Emergency Medicine.
Right. Correct. We're talking about the specific traps the board examiners love to set just to see if you are paying attention. We will cover the rule of 3 and some mock cases to ensure you actually pass the exam.
All right, let's get into segment 1, the landscape. And I want to be honest here. When I think of IPV, I have a very specific image in my head.
Most people do.
Yeah, I picture a middle-aged married couple. Maybe there's a history of alcohol abuse involved. Is that the demographic we're actually looking for?
That is the stereotype. But the data says you are looking in the completely wrong place.
Really?
Yeah. If you are only scanning the waiting room for middle-aged couples, you are going to miss the absolute highest risk group. The text is very clear on this. The peak age for IPV is 18 to 24 years old.
That young. I mean, that's college age, early 20s.
Exactly. And while it affects everyone, women bear the overwhelming burden of injury. But there is an even bigger red flag in the demographics that, honestly, it completely changed how I practice.
What's that?
It involves pregnancy.
Okay, I read this in the source material, and I actually had to double-check it. Pregnancy is a risk factor? I would have thought that would be a protective period.
You would hope so, right? But it is the exact opposite. Pregnancy is often the trigger for the first episode of violence or a massive escalation of existing violence.
That's horrifying.
It is. The data shows that women assaulted during pregnancy are 3 times more likely to be admitted to the hospital than non-pregnant women.
3 times. Why is that? Is there a psychological reason mentioned in the text?
It is all about control. A baby shifts the focus away from the abuser. It introduces a totally new variable into the dynamic. So if you have a pregnant patient with trauma, even seemingly minor trauma, your index of suspicion needs to be through the roof.
Okay, that brings us to the cycle of violence concept. The text breaks this down into 3 phases: tension building, the acute explosion, and the honeymoon phase.
Right. And most of us in the ED, we understand the first 2 pretty well.
Tension building is the walking on eggshells phase.
Exactly. And the acute explosion is the actual assault that brings them into the hospital. But the honeymoon phase, that is the one that really tricks doctors.
Explain that, because if they are in a honeymoon phase, why are they in the emergency department?
Well, usually they are in the hospital because the explosion just happened, the assault just occurred. But by the time they get to a bed, or certainly by the time you are taking a history from them, the abuser might already be pivoting into that honeymoon phase.
Oh, I see.
Yeah, this is the apology tour. It's the, I am so sorry, I love you, I will never do it again routine.
And that spills over onto the medical staff.
It absolutely does. This is the solicitous partner. He is getting her water, he's fluffing her pillow, he is answering all your clinical questions for her. He seems like the perfect concerned husband.
Right.
But he is essentially grooming the medical team to believe that this was just a freak accident or a one-time thing.
That is insidious.
Yeah.
So if we see a partner who is a little too helpful, that's actually a flag.
It is a huge flag. We call it the hovering partner. If he won't leave the room or if he gets overtly hostile when you ask for privacy, that isn't love. That is surveillance.
Wow. Let's talk about the physical exam. You mentioned invisible trauma earlier, but there must be visible signs we miss. Is there a specific pattern?
There is. Think about a standard accidental fall. You trip, you put your hands out to catch yourself,
Right.
you injure your extremities, you scrape your knees, elbows, the palms of your hands. In IPV, the target is the central pattern of injury.
Central meaning the core of the body.
Yes.
Yeah.
The head, neck, face, thorax, and abdomen. This is the kill zone. If a patient says she tripped and fell, but she has deep bruising on her breasts or her abdomen, the story simply doesn't match the injury. Gravity doesn't usually attack your torso while completely sparing your hands.
That makes perfect sense. Speaking of hands, the text mentions nightstick fractures.
Right. If you are being actively attacked, your instinct is to shield your face.
Yeah.
You raise your arms up, so you get isolated fractures of the ulna or deep defensive bruising on the outer forearm. That is a defensive wound by definition.
There is one more physical finding that the text highlights as a major predictor of lethality, and that's strangulation.
This is critical. If a partner is willing to put their hands around a victim's neck, the statistical risk of future homicide skyrockets.
It's an escalation.
A massive one. You need to look for ligature marks, petechia in the eyes, or bruising behind the ears. That isn't just an assault. That is a dress rehearsal for murder.
Okay, that is a sobering transition into segment 2, the evidence. So, say you suspect IPV based on the injuries or that hovering behavior. Now, how do you prove it? Or at least, how do you screen for it without putting the patient in immediate danger?
The next best step here is always privacy. I cannot stress this enough for the residents listening. You cannot screen with the partner in the room.
Because of retaliation.
Exactly. If you ask, is he hitting you, while he is standing right there, she will say no. And you might have just guaranteed she gets beaten worse when they get home for snitching.
But practically speaking, how do you do that? If that hovering partner absolutely refuses to leave the bedside.
You have to get creative. You are the doctor. Use the hospital bureaucracy to your advantage.
Like what?
You say, sir, I need to do a pelvic exam. Hospital policy says no visitors. Or, I need to take her to radiology for a special scan. You can't come for radiation safety reasons. Or even just, registration needs you to sign some financial papers at the front desk right now.
Just separate them physically by any means necessary.
Exactly. And once you have that privacy, you have to ask the right way.
Because saying, are you being abused, feels a little too aggressive.
It's way too loaded. Victims often don't see themselves as abused. The text suggests strict behavioral questions. Are you ever afraid of your partner? Or has your partner hit, kicked, or punched you in the last year?
Direct and factual. I like that. Now, I want to talk about documentation, because the source text seems to have a real vendetta against the specific word that we use in the ED all the time.
The A word. Alleged.
Yeah. I mean, patient presence with alleged assault. I write that because I wasn't there. I didn't see it happen. I don't want to get sued for defamation by the partner.
And that is a very common misconception. But in a legal context, writing alleged implies disbelief. It suggests that you, the attending physician, doubt the credibility of your own patient.
I never thought of it that way.
Think about it. If a patient comes in with a sore throat, you don't write alleged sore throat. You write patient complains of sore throat. A complaint of sexual assault or physical battery is no more alleged than a sore throat.
So what is the fix for our charting?
Quote the patient directly, right? Patient states, quote, he hit me with a baseball bat, unquote. Use quotation marks. That shifts the liability to the patient's statement without casting medical doubt on it. It's a small charting change that makes a massive difference in court.
That is a great pearl. Let's touch on the forensics. If this involves sexual assault, we are looking at the rape kit. The text gets into some specific tools here. Toluidine blue dye and the Woods lamp. I will be honest, I haven't used these often. Can you walk me through what they actually do?
Sure. These are tools to see what the naked eye misses during a standard exam. Toluidine blue is a nuclear stain.
A nuclear stain.
Yeah, it binds to cell nuclei. Normal, healthy skin has layers of superficial cells protecting the nuclei. But if there is a micro tear or an abrasion from force trauma, those deep cells are exposed.
And the dye catches them.
Right. The blue dye sticks to them. So when you apply it and wash it off, the microtrauma lights up as deep blue lines. It documents forced entry or friction trauma that looks perfectly normal otherwise.
And the Woods lamp.
That is a UV light source. Semen fluoresces under it. So it helps you locate biological samples for a collection. It's really about mapping the evidence efficiently.
What about the timeline? How long do we actually have to collect this evidence?
The standard board answer is 72 hours. Some jurisdictions do push it to 96 hours, but the efficacy of the evidence collection drops significantly.
Okay, moving on to segment 3, the management. We are opening the binder. This is the high-yield fact sheet for the listeners. We have diagnosed the trauma. We have safely screened the patient. What do we actually do now?
Well, before we push any medications, we need to provide psychological first aid. You have to validate their experience. The text actually gives a specific script for this.
Oh, what's the script?
You tell them you are not alone. No one deserves an use. I'm concerned for your safety.
It sounds so simple, but I imagine for a victim, hearing a doctor say this isn't your fault is incredibly powerful.
It is the first step in breaking that cycle of violence.
Yeah.
But then, yes, we do need to treat the biology. If sexual assault is part of the presentation, we need to administer a prophylactic cocktail.
Let's break down that cocktail. We are covering STIs, pregnancy, and viral pathogens. What are we ordering for the STIs?
We need to cover gonorrhea, chlamydia, and trichomonas. So it is a 3-drug regimen. First, ceftriaxone, 250 milligrams intramuscular as a single dose. That covers the gonorrhea.
Okay, and for chlamydia?
Azithromycin, 1 gram, by mouth, single dose.
And for trichomonas or bacterial vaginosis?
You want either metronidazole or tinidazole. The dose is 2 grams, by mouth, single dose. And please, for the love of the board exams, write out the full drug names and routes. Do not abbreviate.
All right, spell it all out. Now, pregnancy prophylaxis, this is very time sensitive. We have Plan B and Ella. Are they completely interchangeable?
Not exactly. Levonorgestrel, which is Plan B, is the standard. It is 1.5 milligrams once. It is available over the counter, and it's highly effective early on.
But if they present later?
Right. If you are pushing that window, say, 3 to 5 days out, ulipristal acetate, or Ella, maintains its efficacy much better.
So Ella is the stronger option for a delayed presentation?
Correct. That dose is 30 milligrams as a single dose. But remember, for all of these emergency contraceptives, effectiveness drops significantly after days 4 and 5. Earlier is always better.
What about HIV and hepatitis B?
That is a risk assessment game. For HIV, you have to assess the exposure within 72 hours. If the assailant is deemed high risk, you start post-exposure prophylaxis immediately.
And Hep B?
For hepatitis B, if the patient isn't vaccinated, you give the vaccine immediately. If the assailant is known to be positive, you must add hepatitis B immune globulin.
Okay, so we have treated the patient medically. Now comes the absolute hardest part of the shift, the gray zone. The patient has a fractured arm. We have casted it. We have given all the meds. And now she says, I have to go home to pick up my kids because she's going right back to the abuser.
This is where we have to pivot from doctor to lawyer. It feels terrible, but you have to formally assess capacity.
Capacity in the strict medical sense?
Yes. Is the patient sober? Are they alert? Do they fully understand the risks of returning to that environment? If the answer is yes to all of those, they have the legal right to make a bad decision. They have the right to refuse hospital admission.
Even if we know they are walking back into a meat grinder.
Even then, you cannot legally imprison a patient for their own safety if they have decision-making capacity. However, your job isn't over just because they refuse. You must provide a safety plan.
What does that entail?
You don't just say, okay, sign out against medical advice right here. You give them the hotline numbers. You discuss an exit strategy, a go bag with cash and vital documents. You are planting the seed for the next time they try to leave.
That is frustrating clinically, but I get the legal ethical distinction.
All
right, let's bring it home with segment 4, the PBM edge. This is for the test takers out there. You mentioned a rule of 3 for the boards.
Yes, these are the 3 absolute must-knows for your exam. Number 1 is the fastest killer to rule out.
Which is strangulation.
Strangulation and airway compromise. And closely linked to that is homicide risk. Specifically, the presence of weapons in the home. You have to document that you explicitly asked about weapons.
Got it. Number 2.
The essential bedside test. It is a urine pregnancy test.
Because of the medication choices we discussed.
Because of the meds, yes, but mostly for risk stratification. Remember what we said earlier. Abuse massively escalates in pregnancy. If that test is positive, you have 2 patients, not 1, and you likely need OB consultation and hospital admission. You cannot manage this blindly.
And number 3.
The key clinical pivot. It is the capacity assessment we just talked about. If you discharge a patient to an unsafe environment and something terrible happens, the very first thing a lawyer will ask is, was she drunk? Was she head injured? Did she understand the risk? If you didn't document her capacity, you are entirely liable.
Excellent. Now, it is easy to get these right when we are just discussing them in the abstract here.
Hmm.
But when it is 3 a.m. and the waiting room is full, these cases look very different. I want to throw 3 realistic scenarios at you, mock cases, to see if we can spot the traps in real time.
I am ready. Hit me.
Scenario 1. The clumsy patient. You have a 22-year-old female. She is here for vague abdominal pain. Vital signs are okay, but you look at her chart and she has a history of recurrent falls and accidents over the last year. Her partner is at the bedside, holding her hand, looking very concerned.
Okay, this is a classic board trap. The distractor here is to aggressively work up the abdominal pain, maybe do a CT scan, find nothing acute, give her painkillers, and discharge her.
Because the pain is the chief complaint. You tunnel vision on the abdomen.
Right, but the actual diagnosis is likely IPV. The central pattern potential, the abdominal pain, plus that recurrent history of clumsiness is the real clue, and the hovering partner is the barrier.
So what's the move?
The correct next best step isn't a CT scan, it is separating the patient. You need to get a urine sample or get her to the bathroom alone to screen her safely.
Perfect. Scenario 2. The pregnant presentation. A pregnant patient, 24 weeks gestation, comes in with a doorknob injury to the abdomen. She says she walked into a door. The bruising is localized. It's small. She feels fine. Baby is moving.
The trap here is treating it like minor trauma and just sending her home because she feels fine. It's just a bruise, right?
But at 24 weeks.
Exactly. The rationale is that pregnancy is the peak time for escalation. But physiologically, the fetus is at immense risk for placental abruption, even with what looks like minor trauma.
Because of the shear forces.
Yes, the shear forces can separate the placenta. The next best step is fetal monitoring, specifically cardiography for at least 4 to 6 hours. You absolutely cannot discharge without that monitoring.
All right, scenario 3. The delayed report. A patient comes in 4 days, that is 96 hours, after a sexual assault by a partner. She is hesitant. Maybe she feels guilty for waiting so long.
The trap here is falling into a statute of limitations mindset.
Right.
Thinking, well, it has been 96 hours, the forensic kit is useless, the emergency meds won't work anyway, so we just do a basic exam and refer her to psychiatry.
But we said earlier the ideal window is 72 hours for the kit.
Ideally, yes.
Right.
But you still perform the thorough history and physical, you still offer the prophylaxis. Plan B might not work as well, but Ella might. And the STI prophylaxis is still completely valid. You offer counseling, and you document everything meticulously. You absolutely do not dismiss the case just because the textbook clock ran out. The trauma is still acute for her.
That is a crucial distinction. Medicine doesn't just have a hard stop because the textbook says 72 hours.
Exactly. You treat the patient, not the clock.
Before we wrap up this deep dive, is there a mnemonic to keep all this organized? When things are chaotic in the trauma bay, I really like having a mental checklist.
Yes, keep it SAFE.
SAFE. Walk me through it.
S is for safety assessment. Is she physically safe right now in the department? A is for assess health impact. The physical exam, the labs, the imaging. F is for forensic evidence. The kit, the photos, if it's appropriate. And E is for educate and refer. The safety plan, the hotlines, the go bag.
Safety, assess, forensics, educate. SAFE. That sticks.
Can I leave the listener with one final provocative thought before we close?
Please do.
We talk a lot in emergency medicine about discharging to safety. It is basically our golden rule. But the statistics tell us something truly chilling about IPV.
What is that?
The risk of homicide increases significantly. It actually peaks when the victim tries to leave the relationship.
Wait, so the exact moment they take our medical advice.
Exactly. When they finally say, I am leaving, the abuser loses that control we talked about, and the violence escalates to lethal levels. So when we sign that discharge paper, even if we have done absolutely everything right, even if we have finally convinced them to leave, that might actually be the most dangerous moment of their entire life.
That is terrifying. It means leaving isn't just an event. It is a highly dangerous process.
It is. So when you are on shift, don't just treat the fracture. Ask the question, are you safe at home? and realize that the answer might be incredibly complex.
Keep your head on a swivel. Class dismissed.